Hello again. It's time for the April interview of a highlighted article. Today I will be speaking with Dr. Lykke Ørnbjerg, who's the first author of our featured article titled Patient-Reported Outcomes, Pros and Pro-Remission Rates in 12,262 biologic-naive patients with psoriatic arthritis treated with tumor necrosis factor inhibitors in routine care. Lykke, I want to thank you for taking the time to speak to me and to our listeners on behalf of all the authors of your paper and to discuss the interesting findings. Okay, so we'll start. So could you please outline for our listeners the aims of the study?
Yes, and first of all, thank you for the invitation to join this interview. What we set out to do was to explore the impact of treatment with TNF inhibitors on patient-reported outcomes in psoriatic arthritis patients in a large multinational cohort of patients treated in routine care. And we also wanted to investigate whether these outcomes differed if we grouped or stratified the patient according to certain characteristics.
And so who did you study exactly, the numbers? Well, we know the total numbers of patients, obviously,
yes.
by the title.
Yes.
But what sites were recruited?
Well, this study was conducted on data from the EUROSPAE Research Collaboration Network, which is a research network that consists of 17 European registries who already monitor patients with psoriatic arthritis who are treated in routine care. So what we did was that we were able to identify this large number of patients, 2,262, who initiated TNF inhibitors as their first BDMAT between January 1st, 2009 and December 31st, 2018. So we used already collected data from the registries to create a large pooled cohort of patients.
And approximately, for people like me who aren't really familiar with the cohort, how many countries does this incorporate? Do you remember?
Well, we have 17 registries who are all actually located in just one country. And for this study, we had 12 registries who, and thus 12 countries who had eligible patients.
So very nice, diverse cohort.
Absolutely, absolutely, yeah.
And could just outline what TNF inhibitors and how did they were used, and how did it change over time?
Well, we actually chose the inclusion period to start in 2009 because this is when we have all the currently marketed TNF inhibitors on the markets. So we used all the 5 marketed TNF inhibitors. And what we saw was that when for the first TNF inhibitors, etanercept and adalimumab were the most frequently prescribed. And when patients then switched to a second or third, then it was still etanercept and adalimumab that were the most frequently prescribed, but also certolizumab and golimumab were more frequently used in the later treatment series.
Okay, thanks. And what pros exactly were measured?
What pros? We looked into patient assessment of pain, patient assessment of global disease activity and fatigue, and the HAQ, the Health Assessment Questionnaire. And we chose these pros because they were the most frequently registered outcomes across the registries.
Sense. Very logical. And just so we can get a feel for the cohorts, how many patients approximately would have remained on only one TNF inhibitor, and then we can, and how many received more than one?
Yeah, well, of the approximately 12,000 patients that we identified starting their first TNF inhibitor, then we had data on 4,329 patients who subsequently switched to a second, and of these, 1,240 also switched to a third TNF inhibitor. So we was able to follow the same patient through up to two switches.
Here. And were there significant differences in the pros in patients who, I'm sure if they stayed on the one, they must have done well, but after time on the second or third, did you see significant differences?
We did. We observed a better outcomes for the first treatment than for the second and third. For example, we saw a mean decrease in patient pain from treatment start to 6 months of 2.4 points on a 0 to 10 scale for the first TNFi, and the corresponding decrease was 1.5 and 1.4 for the second and the third. And we saw that the proportion of patients who achieved very low scores for pain, which we defined as less than 2, that was a quarter of the patients for the first TNFi, but only 14 and 9% of the patients for the second and third.
So they seem to parallel DAS28 over time.
Exactly. Yes.
Not surprising.
Not surprising, but also interesting to see.
Sure. No, it's important to see that what we quote unquote objectively measure versus what the patients feel, that they are in parallel.
Yeah.
And since you had 14 different registries, were there any significant differences that you found between the registries, among the registries? Sorry.
Among the registries, yes, we definitely saw differences, and we have seen differences also in other Eurospace studies. We know that there are differences in the patient characteristics of the patients who are followed in the registries, and also in the treatment outcomes. And for example, we saw that after 6 months of treatments in the Finnish registry, the median pain score had decreased to 3. It was 4 in the Italian registry and 2 in the Czech registry. So definitely differences, and not necessarily differences that are easy to comprehend or explain, but definitely a heterogeneous population. Yeah,
it's very interesting, the characteristic. Yeah. As I'm sure it is hard to explain. So, so I noticed that you stratified your patients by disease duration, logically, sex, and age. And during the stratification, were there significant differences as a result?
Yes, we found some quite interesting results when we stratified the patients. We observed that more men than women reach these very low scores of PROs. And we also saw that patients who were diagnosed at a younger age had better PROs than patients who were diagnosed at an older age. And somewhat surprisingly, that patients who had a disease duration of less than 5 years actually did worse than patients who had a longer disease duration.
That's very interesting, that last one.
That is interesting, yeah.
Because that sort of goes a little bit against the DAS28 results, really.
Yes, so that's where you start to speculate about what is it that drive a patient-reported outcome. Yeah. It is probably something different, or not only the inflammation that we as physicians focus on. There might also be something with the impact of having a disease and being diagnosed and learning to live, perhaps, with a chronic disease. That's at least some of our thoughts around that finding.
And it makes it, again, emphasizes the importance of measuring PROs in addition to, again, what we routinely measure. That's very good. And then if you really, could you just summarize the important, what you feel are important messages?
Yes, I think it's an important message that overall we observed marked improvements of patient-reported scores and outcomes when patients are treated with a TNF inhibitor. But also that it is only a minority of patients who actually achieve very low scores of PROs, and that this proportion of patients who achieve low scores differs quite markedly between these groupings of patients that we performed. And we think that that is really something we as physicians should keep in mind and probably look more into what drives these patient-reported outcomes.
Yeah, it opens up again more work for you.
Exactly.
That's good. Keeps you busy. So is there anything you'd like to add that maybe we missed?
Yeah, I think maybe a point around this with the differences in the patient-reported outcomes and the more objective measures, because in our study, we did not look into the more objective measures like CRP and joint counts. So because we wanted to focus on the impact as assessed by the patient, but it also means that we do not have any data that allows us to interpret our finding as differences in inflammation control across the groupings and the registries and the treatment series. So this is really how is the impact of treatment as assessed by the patient.
And I think it'll be fascinating moving forward to look at if there is a discordance between the objective measures in the patient, if treatments change, and in which direction, and which one was the driving force to see if we're, in many ways, do we really take PROs into account and how?
Yes, so it opens up many interesting questions and more work.
Good, thank you. So I want to thank you, Dr. Lykke Ørnbjerg, for taking the time to review the findings of this very interesting paper and the important implications. And to our viewers, listeners, please read the complete paper titled Patient-Reported Outcomes, PROs, and Pro-Remission Rates in 12,262 biologic-naive patients with psoriatic arthritis treated with tumor necrosis inhibitors in routine care. This is currently available at our website, jroom.org, and in the April print edition of the journal. And I want to thank you for joining us and hope you'll join us next month when I will speak to an author or authors of an article of interest to you that I've selected from the May 2024 edition of the Journal of Rheumatology. I'd love to hear your comments on X at jroom or by email at manuscripts@jroom.com. Thank you.